So Will is actually presenting the paper by one of our attendees, Anna Horwood and Michael Brodsky, and he's going to present the paper on intermittent exotropia, and I think is something about are we over minusing by under minusing or something like that. I can never remember the title of it. Yeah. Are we under minusing by not over minusing in intermittent exotropia? And still a minute to go, so we'll wait.
Yeah.
Okay, so Will, you can start now.
Great. Thanks everyone for coming to this journal club, and I'm very happy to start this journal club, pandemic edition. The first paper I'm presenting today is by Michael Brodsky and Anna Horwood on intermittent exotropia, titled "Are We Under Minusing by Not Over Minusing?" So before I go into the detail of that particular paper, I just want to go over very briefly the background of over-minus therapy. So it has been described many times, but I'd like to highlight this paper by Jampolsky in 1983. As we all know that the conventional concept for over-minus therapy is to induce blur and stimulate accommodative convergence to control patients with intermittent exotropia. So in that study, they looked at 35 children with intermittent XT and treated with -2 to -4 diopters of over-minus lens for a median duration of 18 months. And from that, 46% of those children had improved quality of vision, 26% had improved quality of vision with also quantitative reduction in the angle of deviation, and 28% had inadequate improvement in quality of vision, but had reduction in angle of deviation. And that's how we have been practicing the use of, I guess, the therapeutic use of over-minusing lenses in patients with intermittent exotropia. Now, fast forward to 2020, and this paper that I'm presenting today really tried to basically, firstly, blew my mind because it changed the way I've been thinking about the whole process. And I want to just go over that in some detail. So, Prof. Hall has done some experimental studies by looking at the accommodation and convergence measurement in patients. And the study have essentially, in a way, hypothesized that over-minus lenses used in intermittent XT actually eliminate blur and promote fusional convergence rather than to induce blur and promote accommodative convergence. And the study has been done by using a remote hypsoscopic refractor. So my understanding of that is to be able to manipulate the stimulus in front of patient, the subject's eye, by manipulating the blur, the disparity, and the proximal looming cues, and at the same time actually monitoring the amount of accommodation and the convergence or the divergence angle. What the study has found is that in both patients with intermittent XT and patient without or normal patient, the disparity cues actually provided the primary drive for both the convergence and accommodation. And patients with intermittent XT tend to under-accommodate when they are in their exotropic state, so when they are not straight or orthotropic, and they tend to over-accommodate in their orthotropic state. And subjects with intermittent XT actually rely on the disparity cubes to restore binocular alignment with greater convergence stress demand, and as a result, they trigger over-accommodation. And as a result, the image they view will be blurred, and the over-minus or the minus lenses that's being used actually blur their image, and they can see clearer. But whether the mechanism of accommodative convergence and the disparity sort of convergence operate in the same or in different patients remain to be determined. Now, there's also a few clinical findings that support this hypothesis. Firstly, intermittent XT patients do experience diminished vision due to blur under binocular condition, and was first recognized by Bury in 1945, then elaborated by Sieber in 1966, and further documented by Walsh in 2000. And secondly, intermittent XT patients with moderate hyperopia can control their exotropia better when given full cycloplegic refraction. And that's been described by Bucci in 1993. And that description, in a way, sort of suggests fusional convergence is a greater drive than accommodative convergence in controlling deviation in intermittent XT. And thirdly and lastly, there's also clinical findings that we find low to moderate levels of myopia, sort of myopic lenses doesn't really induce long-term myopic shift. So after reading this paper, I do have some questions for Prof. Hold, and in particular, just how much over-accommodation does patients with intermittent XT actually have in comparison to non-intermittent XT patients when they are in their orthotropic sort of state. And follow on to that, how much over-minus should we really be applying for our patients? And are we currently under-minusing? If so, how much more do we need to over-minus? And lastly, just out of my curiosity, what happens in patients with intermittent XT who are pseudophakic, so where they no longer have the accommodative sort of convergence drive, or at least that's my understanding, is if we could correct their distance vision, do they actually hold and improve their intermittent XT more than when they were phakic? Yeah, so that's the first paper. And the second paper that I'm also presenting is a very short editorial piece by Kushner in response to the first paper. And to me, the second paper is even more conceptual than the first one, and actually finished with more questions than I started with. Essentially, in terms of the second paper, things ever as they seem, Kushner introduced the concept of convergence accommodation to convergence ratio, so CA to C ratio, which is different to the AC-A ratio that we are normally familiar with. And my understanding is that we are not so familiar with it because in order to measure that, you require a lot of different equipment, which is not really pragmatic in the clinic setting. He also touched on the conventional ACA ratio measurement, where it can be further broken down into stimulus ACA ratio and response ACA ratio. And when we are measuring ACA ratio in clinic, what we really are measuring are the stimulus ACA ratio, and where we assume that the amount of accommodation occurs is equal to the stimulus applied. So, for example, a -2 diopter lens placed in front of the eye will induce 2 diopters accommodation, whereas the response ACA ratio actually measures the accommodation, and it's not something that we do in the clinical setting. So the opinions expressed by Kushner was the following. So he reported some empirical testing where he is a great believer that the accommodative convergence drives more control in intermittent XT, where his anecdotal experience of using over minus lenses, the amount of over minus that's being used is proportional to the amount of exotropic control you can gain. So -2 diopter lens achieve twice of as much of reduction angle of deviation as -1 and vice versa. And therefore, this sort of supports the conventional hypothesis and the way how we've been applying the over minus lenses. And there's also a question regarding to the duration of over accommodation with convergence. Again, anecdotal experience of relaxing accommodation over 15 to 30 seconds, and how the duration of over accommodation will come into play with this hypothesis of over minusing to correct the over accommodation, which can be potentially transient rather than long-standing. And lastly, there's a question regarding to any new evidence to support whether the over minus by -4 diopter would help to improve those with intermittent XT. So that's the second opinion piece by Kushner in response to the first paper. Thank you very much.
That was really good. Can we have William's questions? Those 3 questions. And
that's on page 6. Yeah.
And Anna, thank you for being here. What would your answers be to those questions?
Okay, yeah, I've had in-depth discussions with both of these, with Bert and with Mike Brodsky about all of this. Our over-accommodation, or a lot of the intermittent exotropia patients don't actually over-accommodate that much. They do a little bit. The main finding that we found was that their response slope was steeper, so that when most people have an accommodative lag at about for close-up, for near targets, you know, they're under accommodating by about a half diopter at least. The intermittent exotropias didn't have as much lag. A few of them did over accommodate, but a lot of them just had a little bit less lag. So it's not a dramatic over accommodation, but those are people who are controlling at the time and they seem to have arrived at some sort of compromise. What a minus lens does, it enables them to do more if they need to. So at the moment, if they've got an intermittent exotropia, they converge and it drives a little bit more accommodation. But if they want to do any more convergence, it gives them accommodative blur, because as they do a lot more convergence, they do an amount of over accommodation that takes them beyond their depth of focus, and then they start to notice a bit of blur. So then they're in a dilemma. They either control their eyes or they get it a bit blurred. And so if you give them an increased minus, it just allows them to do more convergence, brings along a little bit of convergence accommodation, and the minus lenses just make that convergence a little bit more comfortable and less confusing, that they've got clear vision while they're doing that extra accommodation. I don't, so actually not many of them do actually frankly over accommodate a great deal, but they're just doing more than most people do. And the critical thing is that when they lose control, their accommodation then often drops like a stone, and they actually complain. The blur that they're complaining of is the blur that they've lost their accommodation. So when an intermittent exotropia fixates for near and then loses control of that intermittent exotropia, then they not only lose their fusion and their control of the deviation, but they also lose their accommodation as well. So I think that's the sort of the argument that if they're starting to break down for near, that really is a good indication that perhaps somebody should do some surgery, really, because they're starting to struggle then.
And Anna, what's your answer to the second question?
The second question, how much over minus should we apply? I think as much as it takes. I don't think you should give them a lot, because I think they can't keep it up, because if they need to do so much convergence and it introduces so much over accommodation, it's only a very short-term fix. You know, unless they've got a small angle, in which case if they've got a small angle, is there something wrong with their fusion? If they've got a massive angle, then you can only do a certain amount, because it's just a lot to expect them to do. I've lost my train of thought now. I don't know whether we're currently under minusing. I'm not sure whether I agree with Mike. I think the ones that minus lenses work for are the ones who do have a really strong link between convergence and accommodation. And a lot of people don't have that strong link. We're very used to having it in our head that there is this fixed relationship between convergence and accommodation, and everybody always converges and accommodates at the same time. But the thing that we found in our lab is that a lot of people do, but some are quite happy not to. So minus lenses only work if you've got that strong link between convergence and accommodation. If there isn't a strong link, then they just need to be encouraged to converge, because they won't be dragging in a lot of extra accommodation. If they have a strong link between convergence and accommodation, so those are Kushner's high ACA ratio distance exos. So you give them a lens, it makes a big difference to their angle. That shows that they've got a strong link between their convergence and accommodation. And so minus lenses might work for them, because they can't do one without the other. But some people, and a lot of intermittent exos, can do one without the other, which I think takes us on to the next question, is that if you can't accommodate, then fusion is what we're talking about anyway. The blur is an unfortunate consequence of doing a lot of fusion to control your exotropia. And so the minus lenses correct that induced blur. But if you're pseudophakic or if you're presbyopic, then you don't have, you know, however much convergence you're going to do, it's not going to make you accommodate, because you can't. And so their control might, I was doing some teaching in India yesterday, and somebody asked me a very similar question about what happens with presbyopes. Now, I don't think there's a great sort of cliff edge that will drop off when they become presbyopic. That means their intermittent exotropia suddenly decompensates. I think people either control their deviation or not, whatever age they are, but I don't think not being able to accommodate actually makes a huge amount of difference to that control. I don't know whether you'd agree with that. I haven't really thought it through terribly clearly, but I don't see massive numbers of presbyopic intermittent exotropias who've suddenly lost their control.
I guess a lot of selection bias, but yeah. I see a trickle of those patients. Maybe because they've got nowhere else to go, but I see a trickle, especially those with a little uncorrected hyperopia.
Yeah,
I think they're the ones who sometimes do fall off the cliff in their 40s or 30s, but they're pretty rare.
Yeah. I mean, you would think that intermittent exotropia is really common, and you would think that we'd see more if accommodation was the problem. I think the over accommodation is a sort of unfortunate consequence of having to control an intermittent exotropia by fusion. if you've got a strong link between your convergence and accommodation. And some have and some haven't, which is why we get different types of interval. One reason why we might get different types of intermittent exos, because some people just seem to be able to accommodate without converging or converge without accommodating, and others can't.
Well, you've been non-committal about how much over minus should we apply.
Try it and see. I think you just have to see what they like. I don't think there's an answer.
I usually start with minus 150 in a child aged between 3 and 10. I always measure the near acuity to threshold with the end chart. It's typically N3 or N3 plus, and with the Leah chart it's typically 6 on 6, 20/20, and I see how much minus they can tolerate without near blur, and that's commonly 3 or 4 diopters or more, and I'm comfortable about giving them half of that or less as the starting point. Anna, does that, you're nodding, does that?
I think that sounds very sensible, but I do worry that what they can do when we're doing our beautifully well controlled and well thought out tests isn't necessarily what they do when they walk out of the office. So minus lenses only work if they get some benefit from that difference in blur. And I suspect that a lot of kids who've got suppression, if they're suppressing and they don't really care that strongly about being binocular, then whatever you do with lenses, they're not going to bother to accommodate. If they like clear vision and it matters to them, and they're the sort of child who's quite particular and likes to have it clear, then I think minus lenses might well work. I do worry that a lot of them, you give them the minus lenses and they're actually quite comfortable diverging. You know, it depends how strong their fusion is, depends whether they've got any suppression, and it depends whether they're fussy about it being clear or not. And I think for some, it works really well. And for others, I suspect that the minute they walk out of the door or when they're relaxed, they don't bother. It might work when they're doing their threshold close work, but when they're watching TV, it might not. If they're not bothered about, if they're watching a big cartoon, they may not bother to do that accommodation. So they don't mind if it's a bit blurry. So if you're giving them a minus lens in that point and they're not bothering to converge, then all you might have done is just give them a bit of additional blur. So I think what I'm going to say in a minute is sort of about individual differences, and that it works for some kids and it doesn't work for others. Okay. And it's definitely worth a try. And I think that what we're saying is just that the mechanism why minus lenses work is the other way around from what I used to think it was.
Well, thanks, everyone. I think it's time for our second presentation. There's also a few questions that are coming up in the chat box, which we'll get to later if we've got time. Yeah. But yeah, Anna, we can go ahead with your presentation. You're up next.
Okay, I'll try and share my screen. Host disabled participant screen sharing, it says.
Really? Okay. That's unusual. Can you email me the link then? I'll see. How do I?
Okay, I'll have to email you the presentation. Would that work?
That would work. In the meantime, I'll figure out.
Okay. Do you want to do another presentation, and I'll do that in a minute.
No problem. So do we have Raghu and Rahul?
Yeah, I'm here. Raghu.
Are you guys?
I'm here too.
I've got Rahul's presentation with me. So
okay, sir.
How have you guys, Raghu and Rahul will be discussing.
So what we'll do is we'll let Rahul start. Okay. And in the meantime, I'll send you an instruction in the chat box, Shiva, just to you about how you can let everybody share. Okay. So we've been moved forward. We were hoping we could go after Anna.
Okay.
because Krishna's chapter does have quite a bit of things about what we were just discussing. It would be interesting to hear all of Anna's thoughts before we went ahead. But anyway, Rahul will first talk to us about the first portion of the chapter, which is about assessment in intermittent exotropes, and he'll tell us a few pearls that he's picked up that he would incorporate in his practice. And following that, I'll speak about the management bit and talk to you about what I think I would include in my management of these patients. So take it away, Rahul.
Okay, so can everybody hear me clearly? So excellent. So thanks, Shiva, and everyone for organizing and coming together. I think this is exceptional, probably a milestone for our journal club. It's taken it to a new level. So look, this was a fascinating chapter, really. And starting out as a junior consultant this year, certainly it was very enlightening reading Kushner's book. And intermittent exotropes come through my practice a lot. And he certainly really thinks out of the square and does some really interesting things. So Shiva, do you have you're controlling the slides, or how am I doing? Yeah, so Professor Hallwood might not be familiar with this fellow on the right. He's actually the premier or our state leader of Victoria, where we've had obviously a bias in COVID outbreaks relative to the rest of Australia. And so we as Victorians see Exotropia every day at 11 o'clock, which is when he does his morning update on the COVID statistics. But of course, Kushner's chapter starts with this mosaic taken from the Hagia Sophia, which is of a mosaic in Turkey of depicting Christ with a left XT. Whether that's just an artistic error or actually correct. So so we're constantly faced with exotropia, and that was sort of my prelude to going through. So next slide, please, Shiva. So the way I sort of took this chapter was some of the pearls, and I'll get straight into it. So pearl number one, which I took out, is identifying fixation preference is actually important. And one of the contexts in which this becomes relevant is this concept of photalgia. So photalgia is what parents will report is that their child is closing their non-dominant eye in a bright environment, often in sunlight. And this is an auto-occlusion mechanism, which is thought to decrease fusional amplitudes. And it's important to identify which is the non-dominant eye. How do we do this? Well, Kushner talks about observing the behavior of an eye after your uncover test. And this is a very important test and something that I've observed Lionel doing. Essentially what we do, the non-dominant eye, after you, under the cover, it deviates, becomes exotropic. When the cover is removed, there's a slow vergence correction movement back. The dominant eye, however, once you've covered it, it may deviate out. When the cover is removed, there's a relatively quick saccadic movement to take out fixation. And this actually is important to identify. And the other concept that Krishna mentions is that lack of alternation does not necessarily confirm amblyopia is present. And so this is very important also to appreciate. So Shiva, keep next slide, please. Okay, second pearl, sensory adaptations in exotropia. This is also very fascinating, and I think somebody will come to talking perhaps a bit more about this. But when an exophoria develops in a young child with an immature visual system, the child actually has bitemporal suppression, and this is an adaptation to avoid diplopia and visual confusion. And he talks about this being facultative, when it only occurs when the exotropia is manifest. Now, the size of this suppression, scotoma, is not typically absolute. And interestingly, in a neurological concept, the size of the scotoma is inversely proportional to stimulus intensity. But in this setting, the size of the scotoma is perceived to be proportionate to the light intensity that's stimulating. So how is this practically relevant? Well, for example, at night or in a dim environment, when the stimulus may be reduced, then some of these patients may in fact report diplopia because there's less stimulus intensity, and therefore the size of the suppression scotoma is diminished. Next slide, please, Shiva. And so one of the clinical tests that I've observed Lionel doing, and we actually have this in our clinic, is the brand name is the Spicer bar, but effectively this is a variation of a neutral density filter. And one of the ways that Kushner talks about it is holding a light stimulus at the end of a corridor or examination environment while the patient is tropic, and introducing the filter bar with progressively increasing density. And this may actually bring out diplopia, which is not obviously apparent. And you'll notice on the Spicer bar there that there is actually some numbers, and you can actually document this, and in terms of when to quantify when the patient, if they do, appreciate the sensation of diplopia. So a very underrated a piece of equipment, but I know the orthoptists use it regularly, and I've seen Lionel do it many times. Next slide, please, Shiva. Now, we talked about the Burian classification. I don't want to go through this again. I think William presented very well. But the next slide is really what are the issues, what are the limitations with the Burian classification, which is raised by Kushner. So firstly, he talks about this concept of divergence excess type. It's not truly an excess of divergence, but more a dampening of convergence. It's really interesting. And I think Professor Horwood may touch on this further. Now, the other concept that was very interesting is that monocular occlusion and plus lens findings are not the same. So when we're doing patch testing and recording your measurements, and conversely, if you put a plus lens at near to see the near deviation, this is not looking at the same concept. We're actually talking about, in one setting, disrupting fusional convergence, which is monocular patching, and plus lenses, which are decreasing the accommodative convergence. And this becomes important because Burian talked about, well, if you do a bilateral lateral rectus recession, he was postulated that typically has more of an effect on distance deviation more so than near. But in reality, it actually should have sort of an equal effect on distance and near, as we see in a basic exotropia setting. And Jampolsky added to this further, and he said that the distance near discrepancy that we see in these exotropic patients is due to this AC by A amplitude. The next slide, Shiva, please. So this leads to this fascinating concept of the SCOBY phenomenon, and I think it deserves its own journal club in itself. But in 1952, SCOBY described a common scenario in which patients with intermittent exotropia may have a large deviation at distance fixation and a much smaller or no deviation at 1/3 of a meter or closer distance. Yet the near deviation will increase to approximate the distance deviation after a prolonged period of monocular occlusion. And this led to this concept of the SCOBY phenomenon. Contributing to this is this thought of tenacious proximal fusion. Now, Kushner talks somewhat, he introduces the concept of tenacious proximal fusion, but he says that this is a part of the SCOBY phenomenon. So he prefers us to think of the SCOBY phenomenon as more of a broader entity that incorporates tenacious proximal fusion. And within TPF itself is the thought that there is binasal or uncrossed retinal disparity that occurs with near fixation, and this may contribute to this observation. And how is this practically important? Well, if you're measuring the AC by A gradient, the SCOBY phenomenon will affect any near measurement that we use. And so Kushner says that when calculating your AC by A, either using a gradient or heterophoria technique, you really should do it after a patch test. And really, that's the proper way to do this. And otherwise, you're not really accounting for the impact of the SCOBY phenomenon. So that's another practical pearl. Next slide, please, Shiva. This was also very fascinating, and I wouldn't mind Shiva's input, who's actually observed Kushner doing this. Now, he talks about, when considering surgery, measuring the exotropia by having a patient fixate on a distant outdoor target. So Kushner actually gets these patients close as possible to the window of his examination room, looking out into a distance target and measuring. And in his personal series, he's documented the rate of undercorrection by doing this distance measurement in this manner. It goes from about 40% to 18%. Now, unfortunately for many of us, we work in sort of concrete hospital rooms, and this is difficult to emulate. But I'll be fascinated to hear of amongst the panel who actually does this, and if they've audited their own results. And he also makes a point that in all patients with intermittent exotropia undergoing surgery, he encourages at least one measurement, if not more, after a period of a monocular patch. So we don't always have the time to do the full occlusion of Marlowe, which is a fascinating paper from the early 1900s, but at least 45 to 60 minutes of monocular patching. And this is to account or assess accurately the impact of the SCOBY phenomenon. Next slide, please, Shiva. So this is a table in the chapter comparing the Burien classification to Kushner's and certain comments. And I've just left this up here because the next few slides really talks about some practical scenarios that we see commonly in day-to-day practice. So next slide. So Pearl 4 is really, Kushner's classification is useful. And I'm going to show you 3 scenarios which are common. Scenario 1, consider a patient with a distance xt which is greater than the near measurement, but the near measurement increases after your monocular patch. Now, Kushner talks about that these are the patients who exhibit the SCOBY phenomenon, and they do well with either bilateral lateral rectus recessions or recess resect unilateral. And Raghu will complement this by going into a bit more of the rationale. Next slide, please, Shiva. Scenario 2. What happens if your distance xt is more than the near initially, but your near xt increases after the patch and after giving a +3 measurement at near? And Kushner talks that in his personal experience, this is the most common type of intermittent exotropia that he sees in his practice, approximately 43%. And he talks that these patients actually have a pseudo high AC by A. So this is really next scenario, and I'll compare this to the final one, which is next slide, Shiva. So in this scenario, the distance xt is greater than the near initially, and the near does not increase after the patch, but it does increase after putting up a +3 at near. And he says that these patients may have a true high AC by A ratio. Fortunately for us, most of these cases fall into an uncommon variant of intermittent XT in his series. And this becomes important because he states that identifying true high AC by A is critical, because if you apply standard surgery numbers correcting for, say, distance, then the near measurement, they may become esotropic at near. And so he postulates that there are several approaches, trialing of over minus, perhaps with bifocal component at near. And he also adds this interesting point that in his experience, the child may outgrow this high AC by A, usually as they approach adulthood. And then they can be operated using sort of standard numbers afterwards. So I'd like to get the panel's thoughts on this concept too. Next slide, please, Shiva. William has touched on this. Pearl 5, understanding the physiological entities of convergent insufficiency is important. It's often clumped together, but we know that there's fusional convergence insufficiency, and then there's accommodative convergence insufficiency. So the fusional group, there's typically minimal or no exophoria at distance, but a large exophoria sometimes at near. And the size of the near to distance discrepancy is usually less than 15 prism diopters. And is believed to be due to decreased fusional amplitudes. And often these patients will present with a headache, asthenopia, may or may not have diplopia, and they respond well to orthoptic exercises. But it's important to distinguish this from your accommodative convergence insufficiency group, where there is a large manifest exotropia at distance, which can be intermittent or less constant, but it's larger, much larger at near. And the discrepancy is usually larger, so more than 15 to 18 prism diopters between your near to distance. And these patients typically have little or no accommodative convergence. And so your treatment is either to correct for the distance, or, which is a fascinating concept, the work done by Ed Buckley, and in transposing the recti to correct a V pattern, and basically so I'll go to the next slide. I'll sort of be able to explain this. So Buckley described this many years ago, in particularly in this group, patients with convergence insufficiency type exotropia. And what he did was supraplacing the medial recti in combination with small resections, usually a tendon width, and you can address this as if we're treating an A pattern, and therefore inducing a V pattern to minimize this issue that we have of ET at near. And Lionel and I, interestingly, Lionel's collected a series of these patients that he's performed surgery for a large angle distance more than near esotropes. And we've used a super placement approach as well. That's a separate topic, but this concept was first pioneered or conceptualized, I guess, by Ed Buckley. So fascinating surgical approach to this near distance discrepancy. Next slide, please, Shiva. Pearl 7, sensory tests and motor control. So Kushner really states that he relies more on the motor control, so the angles, to influence treatment decisions. He does mention that there is data to suggest that deterioration in distant stereopsis may closely parallel control in deviation, and that this decrease in distance binocularity may in fact reflect over accommodation to control the XT. But in my clinic, I don't really have a great way of assessing distance stereo, so I'd be interested to see what other people do in this regard. And Kushner relies more on his motor numbers to guide his treatment decisions. Next slide, please. So there's some pearls that I took out of the first chapter, the first section of this chapter, and I'll leave it to Raghu to discuss the sort of the treatment aspect of it.
Thanks, Rahul. I think I figured out how to let everyone share thanks to some comments that I got in my chat box. So hopefully I've enabled individual sharing. So hopefully it runs more smoothly now. Okay. Now, Anna, do you want to go next, or should I? Does Raghu go?
Yeah, it might be good if I. Oh, hang on. Yeah, you can hear me. Might be good if I went next, perhaps. Let's just see if I can share first of all. Oh, look, maybe. There we go. Can you see that?
Yes.
You are screen sharing. Okay. Okay. Lionel said, could I come to this meeting and explain this paper to everybody? I'm not sure that I can exactly, but as I say, I do have, Mike Brodsky's a real blue sky thinker, and every so often I get an email from him. It's a sort of, what do you think about this sort of thing? And obviously when he was planning this paper, we had a little bit of a backwards and forwards about what was in his mind. And I think I sort of get what he's talking about, but he might disagree that I have misunderstood. He is much more into the sort of evolutionary neurophysiology sort of aspect of thing, that I tend to be a bit more on the practical side. But I think what he's trying to say is that the conventional view of intermittent exotropia is that there's a basic divergent angle. So the problem is a divergent angle, and then it's controlled by either accommodation or fusion. Some have a high ACA, some not. Some have, as Kushner and Scobie and people will say, have tenacious proximal fusion, some don't. But there are inconsistencies, and so the surgery that you plan sometimes doesn't turn out as it should, however hard we try to measure it. That the things that you would expect to affect both angles don't, or something that you would expect to affect one of those angles affects both. And I think that's sort of where he's coming from. The fact that there are relatively few surgical overcorrections when there is a near distance disparity. And then I think I think he'd been listening to our talks about sort of an overarching model of how convergent accommodation work. And I think then he took it a little bit further and was thinking about accommodative esotropia. And the theory there is that you have the basic angle is straight, the basic angle isn't ESO. And then you have hypermetropia and a high ACA ratio, which leads to an accommodative esotropia. But again, I think the sort of the common theme he was trying to say, there are inconsistencies in that too. And again, relatively few overcorrections, particularly for if you're doing biomedial or recess-resect, if there's a near distance disparity, for instance. And he shows a few papers and evidence that Fourier adaptation occurs in accommodative esotropia too. Now, he quoted a few papers, and there's also another one by Tess Garrity and Strabismus a couple of years ago, who looked at prism adaptation in convergence excess esotropia, which I struggled to get my head around the mechanism, and this might have something to do with it. I don't think what he's suggesting is the whole answer, and there are still lots of questions, but I think it's an interesting take on it. And I think this he won't mind me quoting this, but this is a quote from an email that we had just before this paper came in, and it was sort of thinking about his mindset at the time, I think. So it occurs to me that Fourier adaptation may explain why our vision is blurred after reading off iPhones for long periods. It's not just a feeling of blur, but a complete feeling of misregister, complex feeling of misregister. And I think it got him thinking about Fourier adaptation, and I think that's the point. And maybe the convergence drags a little hyperaccommodation to produce blur. So I think his take on it, hang on a minute, I just need to I've moved everybody's little pictures and they're now in the way of what I can see. I think he's saying that Fourier adaptation, which we know is a slow vergence mechanism that we can't really test for terribly easily. Prolonged occlusion certainly does it, but it's not elicited by cover testing, which is the thing that we rely on so much. Slow to build and to decay, and it takes hours or days, and maybe it takes years to build in children. And it may be that this slow build of Fourier adaptation may be more important than we're thinking. He's saying that is possibly under higher neural control. The thing about the literature of Fourier adaptation is that usually it's done in labs, it's done with people without big problems, and it's usually induced with prisms. I don't think the scientific world has looked about how it's acting in Fouriers and intermittent tropias. So I think what Mike is speculating on may well be true, but I'm not sure where the evidence is in the sort of patients that we're seeing all the time. So do these lab studies in normals extrapolate well to large deviations? Because we know that in extreme cases of all sorts of things, people can learn to do all sorts of weird and wonderful things. They can learn to either accommodate, they can learn these massive vertical fusion ranges that we see in congenital fourth nerve palsies. And so it may be that intermittent exotropias are just doing an awful lot more, or intermittent deviations entirely are doing a lot more Fourier adaptation than perhaps we think. he went on to discuss the fact that convergence is an on-off system, that Jan Polsky raised the point that convergence is an on-off system. So you're either converging and accommodating or you're not. You're not doing any active convergence or anti-accommodating. And another point that he gave is, in one of his emails to me, he sort of says, Cliff Shaw says that disparity alone doesn't do it. The patient has to be actively trying to fuse. And I think we do underestimate this effort of awareness and motivation and trying, and you've got to be able to have some sort of motivation, whether that's a conscious or an unconscious motivation to learn to fuse. I think that's what he's trying to get at. So he's saying, I think, that there are two ends of the spectrum. So, you know, he says that there's a spectrum from blur-driven accommodative convergence at one end of the spectrum. So mostly they're using blur to change the control of the deviation, to disparity-driven convergence accommodation at the other end of the spectrum, but no inherent innovational differences. And so I think he's thinking at a neural level that the innovation systems are the same, but people are just placing themselves along a spectrum in slow and fast responses and accommodative or not responses. And, you know, normality sits in the middle of this, and we are working at the extremes of this spectrum. And he's saying that both esotropia and exotropia use these slow Fourier adaptations to mask large basic angles and begin it to bring them into a limit when we can start to use the things that we're used to dealing with. So the fast responses, fusion and accommodation in the way that we normally talk about it. And because disparity is a stronger system, it usually predominates. But I think he's saying that in intermittent esotropia, the basic problem is a basic esodiviation, and it's controlled by tonic divergence rather than the basic angle being straight, being made abnormal by the accommodative stimulus. And I think that's where he gets that spectrum thing, that basically the accommodative esotropias are basically ESO people controlling in the distance by tonic divergence, and the intermittent exotropias are basically large angle exos controlling for near with fusion. And then he's saying that once you use these slow adaptations, then the normal ACA, CAC mechanisms that we're going to be talking about most of the day can act for environmentally useful reasons. So, for instance, in exotropia, they're controlled for near. It's environmentally very useful to have stereopsis for near. Stereopsis isn't so important in the distance, and whether you're suppressing or not doesn't make much difference to your acuity or to your functionality, whereas losing your binocularity for near, losing your stereopsis, is the main prime stimulus for exos. I think that he's trying to link what we're doing, talking about using different cues to control, to explain the clinical characteristics within that model. Yeah, and I think that he's saying that that vergent adaptation is still active in the background. I do sometimes struggle to follow the reasoning behind it, and I think we need to sort of sit down and work it out. But I think it's a good theoretical framework to think about, and I think it might point out that perhaps we should take more notice of angles after prolonged dissociation and with plus lenses, like we are sort of used to doing in intermittent exotropia. We're used to occluding them, and we're used to seeing what they do with different lenses. It might be that we ought to be doing it with more of our intermittent patients. It also brings this point about individual differences, and individual differences is the big scientific thing at the moment in psychology and in everything, in genetics, and it's all about individual differences. he's saying that there are the effects of Fourier adaptation become mixed with all the other things. So disparity-driven non-accommodative convergence, blur-driven accommodative convergence. So that's where the spectrum thing comes from, that it is placing yourself on that spectrum. For years he's been talking about this sort of fish-rabbit theory, that if you have laterally placed eyes and you're a prey animal, then you're not so environmentally predisposed to need fine stereopsis, whereas forward-facing predators have good stereopsis. But I think he's sort of saying that that might account for some of the blur disparity preferences, because if you're a prey animal, you're more likely to be evolutionarily attuned to blur. But if you've got forward-placing eyes, disparity, if you're sitting doing some fine motor task, or you're a hawk going for a mouse, then forward eyes, disparity is the more useful cue, because it's so many more times more precise than blur cues can ever be. And possibly these nasal temporal retina differences and hemiretinal suppression play a part. So whether it's also somewhere where you place yourself on the evolutionary spectrum. So disparity is certainly a higher process when we talked about this and blur. And the fact that strabismus patients may have enhanced or different vergence adaptation. So I think that some people just have a desire for binocularity, and some people will have slow or fast responses, and some people's individual solutions to controlling their eyes might be different. For some people, it may be that they've used their slow adaptation to enable them to control. For others, they're relying on the fast systems. And so our job is to try and work out which one of those systems they're relying on. Because if you rely on the slow systems, then your true angle will only be revealed by a lot of dissociation. If you're relying on the fast system, then it's going to be much more, it's going to be affected by lenses or a cover test dissociation, for instance. And so I think that spectrum fits this individual differences. I think there are a lot of questions, and I'm not sure whether I have any answers to these. Firstly, what determines the position of rest? What is it that makes us primarily divergent? So is it orbital? Is it ocular muscle anasopy? Is it inherent muscle tone? What determines how strong that Fourier adaptation is? So if you're one who has very strong Fourier adaptation, is it because you have a stronger desire for BV, or it's something about your neural wiring, or is it just that you just have inherited it? But we can get some handle on it by this reaction to prolonged occlusion or prism adaptation. Coming from my side of things, what determines whether you're going to use blur or disparity or proximal cues? What determines your desire for stereopsis? What determines the strength of your ACA ratio or ACA linkage? I try and avoid the word ratio if I can. But what is it that makes us desire to use accommodation and convergence, or desire to have strong proximal fusion? Does it determine emmetropization? Is it influenced by heredity? Is it influenced by how dissociative a stimulus is? Is it even to do with IQ or personality or emotional arousal? We all know that convergent success exotropias tend to be a sort of fairly particular personality type, and some intermittent exotropias can be a certain personality type. So is something like emotional arousal or personality determined how people do it? And what happens when at 4 months of age, when they're probably transferring from two separate fixation mechanisms, which seems certainly a possibility, to true BV, when stereopsis kicks in at 4 months? Is there something that just at that tipping point in the first few months of life, as they're learning to be binocular, they're learning to deal with where their eyes are stuck in their orbits, is it then that they develop a way of the way that they're going to do it, and do they just head off in different directions? And all of this assumes that they've got binocular vision. And so we're talking about intermittent strabismus here. So what happens if it doesn't? What happens in constant deviations with constant suppression? Lots of mechanisms are they using? You know, and that nobody's even thought about those yet at the moment. So I don't have any answers, I'm afraid. I just have a few more questions. And I think that certainly it suggests that perhaps we should occlude people more regularly, not just intermittent exotropias, to see what happens to their angle. We need to be very careful about how we measure it. After we've done that occlusion, you don't let them have a second of being binocular before you do a measurement. Maybe we should prism adapt some people. Certainly experimentally, it might be useful to prism adapt them. I don't know whether that's practical clinically. So lots of questions and not many answers, I'm afraid. So I don't know whether that makes sense, and I'm not sure whether I entirely understand where Mike's coming from. But I think that's probably where it is, that it's about individual differences and it's about a patient placing themselves on a spectrum with all of these systems interacting and having to be balanced.
Anna, that was, you've explained many of the pieces of the jigsaw puzzle.
Oh, good. I'm glad you think so.
And thank you very much. I'm going to play your talk again.
Yeah, well, I don't know. That's where I think he's coming from, and I think it's where I'm coming from. I think it's coming from the fact that everybody does it differently, and it's our job to work out how they do it. And particularly in intermittent exotropia, we're further along the line of knowing how to do it. You know, we do sort of routinely occlude them, and we routinely assess what their angle does with lenses. And so we're a little bit more along that line about it. There are a few things that cropped up that in the questions that we might come back to later. But yeah, I think it's a really mind-boggling topic. It's just not quite as simple as everybody says.
I think I've read this paper 3 times and I still don't understand it, but that was...
Even I know where he's coming from, and I'm still not exactly sure, but I think it's to do with evolution, and it's to do with environmental necessity, and it's to do with, well, I would call it individual style, but it's placing yourself on a spectrum. And I think that a baby who is stuck with a pair of anatomically divergent eyes has to work out how they're going to do it and how strong is their binocular. It may be that have those little binocular cells in your cortex kicked in 3 days earlier, and so you've got stereopsis just a tiny little bit earlier than something else has developed, and it may be that it just heads you off in one trajectory or another, and then you're stuck with thinking, well, now my eyes are doing this, what do I need them to do? Am I aware of what I need them to do, and how am I going to solve that situation? I think babies just probably arrive at their own model. I mean, Tricia Riddle, that I work with, is very keen on this parsimonious to do with neural pruning, that when you're a baby, you can do things lots of different ways. You can use lots of different cues. You have all these things available. You work out which is statistically the most successful. So, you know, this is for my eyes, my IPD, my refractive error. If I do this, more times out than not, it works. So this is the one that I'm going to neurologically develop, and the other pathway might get pruned down. So suppression might be quite a useful thing for some babies with a very large deviation in the distance.
Okay, thanks, Anna. I think Raghu's going to present the Kushner text chapter part 2, a continuation of Rahul's presentation. That also, I think, may talk about similar concepts. Raghu, happy for you to share your presentation.
Thank you, Shiva. Now that we've all agreed that this is very complex and we don't understand much about it, I feel much better making my presentation. Okay, so treatment of this very, very complex condition as per Kushna. I'm just going to talk about a few things that he's mentioned here. It was great to listen to Kushna's keynote presentation a week or two ago at WSPOS on the exact same topic. So it was good to get a few tips from there as well. I've tried to incorporate those as well. In fact, I've borrowed a slide or two from him from his presentation. So there's a better picture of Daniel Andrews holding a Bible even, and clearly under stress, his exotropia becomes a bit larger, as you can see there. All right, so the first question is, when do we treat intermittent exotropes? Kushna thinks that this is primarily based on the frequency of deviation rather than the amount of deviation. We depend heavily on parents telling us if their children are unable to control the deviation for more than 50% of waking hours. But in actuality, this is very difficult for parents to assess, because if there's a small angle esotropia that is there, also exotropia that is present for a lot of the time, it's probably harder for the parents to gauge than if there's a large angle XT which is present for a shorter amount of time. They probably feel it's a lot worse. So Kushna suggests that we watch for trends in control rather than asking parents for 50% more or less. Especially trends and control in the office. When we look at them, we measure them and see if they break down and how quickly they recover. And of course, symptoms also, sorry about that. I think you may have lost my slides. Just gonna go back there. Okay, and symptoms also dictate when we treat. The next question is, how do we treat? So non-surgical treatment options include alternate day patching, which Professor Horwood was just talking about. So 3 to 4 hours a day, alternate day patching. The thought behind how this helps is that it helps by eliminating suppression. When suppression decreases, there's diplopia. When there's diplopia awareness, there's a stronger drive to keep the eye straight. How much, or whether you do 1:1 or 2:1 or 3:1 depends on how much fixation there is. So for the freely alternating ones, you do 1 day on the dominant, 1 day on the, or 1 day on each eye. For the stronger fixation preferences, you do 2 days on the dominant eye and 1 day on the non-dominant eye. And you see them in 1 month. Sorry, I'm just going to get rid of that. They're almost, Kushna thinks they almost invariably show better control and, interestingly, a smaller angle. You wean and discontinue this and repeat it if necessary. Kushna thinks it buys some time and sometimes even cures, so these people may not need surgery. Can we use it prophylactically? So can we use it for someone who isn't fulfilling our criteria for treatment? The answer is no, and this is backed by a pediatric study which looked at whether we should start alternate day patching for children who don't fulfill the criteria for treatment, and the answer is no. Also, will pharmacological penalization work as well as patching? Kushna thinks definitely not. He thinks it might in fact make things worse because you're introducing blur in one eye. And of course, there's no evidence for pharmacological penalization either. Over-minusing, which we just had a bit of a conversation about, as we were looking there. Kushna gives them -2 diopter sphere, so that's what he goes to for his minus. He also puts in a Bayesian prism. Now, I found this interesting because I haven't done this routinely. I would like to ask others on the panel if they've been doing it routinely, adding in the prism. And of course, the mechanisms, as we just heard, Jan Polsky and Kushna thinking more about the accommodative convergence, and Professor Horwood introducing the concept of fusional convergence. To answer one of the questions in the chat, Kushna thinks this was most useful in children under the age of 7 to 8. The question of whether this leads to myopia progression, I think he does mention a few papers where it's been made fairly clear that these children are anyway prone to myopia and progression, and it's not the treatment of over-minusing that's causing that. Kushna believes exercises are not really useful in intermittent exotropias. The next question is surgical treatment. What do we do? What's the timing? So Kushna believes we should defer surgery in children less than 3 because there's a risk of subnormal fusion and the risk of monofixation is higher. is this because of overcorrection, or is there a selection bias? Are we only operating on kids under the age of 3 who already probably have subnormal fusion and wouldn't develop good fusion anyway? We don't know. Temporize with non-surgical means if possible, and if not, avoid prolonged post-op esotropias. Target angle as per Kushner, for all patients, he, as Rahul said, does a 45 to 60 minute patch test, takes them to the window, stands as close, makes them stand as close to the window as possible, just enough space for him to get in and do a cover test on them. And he does surgery on the largest angle that he finds. He aims 5 to 15 prisms overcorrection in children, and he recommends avoiding any overcorrection in adults because he believes that they do not have an exodrift like children do, so they would end up having esotropia and diplopia. He, in his talk, he said that he would get them perfectly straight to the point of them having, just to the point of them having diplopia. So this is a slide from his recent talk. He, as Rahul pointed out, he believes that Buren's recommendations for his classification and also for the surgery are based on the false assumption that lateral rectus recession affects distance more than near, and RNR affects distance and near equally. His thoughts are that for the divergence excess type, which he thinks is actually just a masked near deviation because of convergence, he would prefer anything that you prefer would be good. For the basic type, Kushner believes that the basic type is something where the Scobie phenomenon is absent, where the distance and near XT are equal. He calls the Scobie phenomenon actually a good fusional phenomenon, and because of that, he feels that they need a bit more stabilizing surgery, as he calls it. Recess resects, as per him, are more stabilizing than just a lateral rectus recession. But if you do a lateral rectus recession, he recommends adding 1.5 millimeters, so an enhanced lateral rectus recession, and that he felt in his hands had given him good results. For the pseudo divergence excess, where the Scobie phenomenon is present, again, your choice. For the true high AC by A intermittent exotropes, which he thinks are a very, very, very small number, he says that there will be esotropia for NIA after surgery if you leave them ortho for distance. He recommends avoiding surgery for as long as possible, use minus lenses and bifocals. And if you do have to operate, he says, recession of LR with posterior fixation of MRs has given good results. He then goes on to say that he hasn't done it much, so he's not very sure about what the results would be. Accommodative, for the accommodative convergence insufficiency, where they have a smaller XT for distance, or intermittent XT for distance, and a larger XT for NIA, he recommends a MR resect or an RNR, and also Rahul mentioned the Buckley procedure to induce a V pattern in these patients. Coming to some of the complications or over and undercorrections following surgery. So how do you treat a persistent overcorrection? So if they've been left in esotropia, if they do have diplopia, he recommends part-time occlusion. If they do have Fresnel prisms, if they do have diplopia, he also says we could use Fresnel prisms to offset the deviation. Under the age of 2, he starts treating overcorrections within 1 week because he's worried about them then going on to develop subnormal fusion. If the overcorrection is due to a limited abduction following recess resect, he gets them to do these exercises where he gets them to fixate on an object and abduct with the other eye closed in the hope of stretching the resected muscle. If this is unsuccessful, then he recommends using Botox. He feels that the best long-term results are in patients who have a small angle persistent overcorrection for a long time, even a year or so. He talks about this blind spot syndrome, which was quite interesting. So these patients initially have a small overcorrection, just as we had planned, but that slowly then builds up to 25 to 35 prisms of esotropia. This happens because they have diplopia, and then they overconverge to bring the eye to the blind spot, and then that way they don't have diplopia. The treatment is to give them full-time alternate occlusion to break the drive to overconverge, and then get them into your office a week after they've been doing the full-time alternate occlusion, and then measuring them just before they become binocular. And if the angle is much smaller, then that proves that this is probably the blind spot syndrome. In this case, using the prisms to offset diplopia will take away the drive to overconverge. He also says you could do a peripheral iridotomy for this. I didn't quite understand how that would work. I was hoping someone on the panel could shed some light on that. What do we do for undercorrections or recurrences? If there was an initial recess resect done, then we just do a recess resect on the other eye. If there was an initial bilateral lateral rectus recession done, then resurgery depends on the amount of recession and the incomitance in side gazes. If there's lateral incomitance and the deviation decreases by 10 prisms in both right and left gazes, then he recommends doing MR resections, not doing any more LRSS. But if there's no lateral incomitance and if the initial recessions were smaller than 6 millimeters, then further LR recession is okay to do. This was about consecutive exotropias. So people who still remain exotropic. Cutting plus in glasses is only a temporizing measure as per him. If they have had a previous RNR with full adduction, then the other eye can have an RNR. Prior MR sessions with full adduction, you could do a bilateral lateral rectus recess. And prior MR recessions with adduction limited, you explore the MRs looking for a slipped muscle or a stretched scar. Now, this was the pearl of the chapter for me. If a consecutive exotrope has a near deviation that exceeds the distance even by a few prism diopters, it results in subsequent LR recessions giving very disappointing results and a high undercorrection rate, even if the assessment of adduction was normal. I now take this pattern of mild convergence insufficiency to be a sort of MR underaction, and these patients do much better with MR advancement rather than doing LR recession. So this was really interesting for me. As per his previous slide, this is what I had been following, where, you know, if they had full adduction, I wouldn't really, or even if I explored the MR, if I found that it was where it should be, I would probably just proceed to doing bilateral lateral rectus recessions. But even a few diopters of difference in the near and distance deviation should make us think of this as a soft sign for MR underaction. And yeah, just ending with a beautiful picture of Melbourne, which looks as beautiful even in lockdown.
That's great, Raghu. Thank you.
Thank you.
I think we've covered most of the conceptual papers on intermittent XT, convergence and accommodation. We can have a couple of minutes to discuss before we go on to the pedic studies and the infantile XTs. So any questions that anyone has?
Can I introduce a possible alternative explanation for what to do with the consecutive esotropias? I agree with Kushner that these true high ACA deviations have a higher chance of going in. I think there's another explanation for it. I think a high ACA ratio or a high CAC ratio tells you that they can't do one without the other, whichever the direction is, that they can't accommodate without converging. These kids have been converging all their life, and they've associated a large amount of convergence with a normal amount of accommodation. So if they need to accommodate 3 diopters for near, they're used to doing it by also converging 45 diopters. If they want to control for near, they've got to converge 45 diopters and accommodate 3 diopters. Those two are linked. So when you reduce their 45 diopters and take it down to 10 or 0, all of a sudden they've lost a primary drive to their accommodation too. So they can't converge without accommodating, and they can't accommodate without converging. So if they've got to accommodate because it's blurry for near, and the only way they've ever got used to doing it is by doing a lot of convergence, they can't suddenly not have to converge and then accommodate. They have to learn to separate those two systems and develop a new relationship. So the logical short-term fix is possibly bifocals. You've turned them into a hypo-accommodative convergent success deviation. They can only accommodate if they then continue to do more convergence. So they have to relearn that they have to be able to accommodate without converging a lot. So some of them just reset. You know, in a few days, you reassure them it will probably go away. I think maybe it might be a good idea to ask them to do a bit of monocular accommodation exercises, just to sort of say, well, actually start thinking about making it clear, forget about, you know, and just concentrate on learning how to accommodate through a different route. Maybe try plus lenses, bifocals, as an option. It's how you would treat a convergent success with the same clinical pattern. So I haven't got any clinical evidence, but I think it might be worth a try as an alternative. If you buy in that explanation that by taking away their big angle deviation, you've taken away what used to be their primary drive or their primary concomitant with their accommodation. Just an alternative.
Thanks, Anna. There's a follow-up question to what you just said. So Kathy Lewis, who's the chief orthoptist at the Children's Hospital, has asked a question. So if you have a consecutive EZO patient, could you improve their binocular functions through stereograms? Could they do stare through stereograms?
Well, I'm sure you could. I'm not very good at getting people to do stereograms. I think stereograms are one of those things that we can show them what they have to do. They have to go away and learn how to do it. So I can say, this is a good skill to have. Go away and practice, and we can show them how to practice. And then suddenly, particularly distant stereograms, they suddenly just catch on to they've suddenly learnt to dissociate their convergent accommodation. So the first stage of teaching stereograms is just to teach them to fuse those, to get those three pictures, whether it's blurred or not. The next stage, which is what the whole point of stereograms about, is to dissociate their convergence and their accommodation. I don't know how to teach somebody to do that. All I think I do is say, go away and keep doing it. And one of these days you'll go, I've got it. It's like those magic eye pictures, that it's one of those tricks that we show them. This is a useful skill. To be able to dissociate these two systems is a useful thing to do. This is a trick to do it. Go away and practice and it'll come to you. I'm a bit humble. I'm not sure whether I can actually teach somebody how to do it, but I can say that it's that feeling of your eyes when your accommodation's relaxed or when your convergence is active. So that's the best answer I can give, I think.
Thank you. Okay, any further questions for Anna, or we can go on to the next presenter? Okay. Well, I think Elad, you're next. And Elad will be presenting the two recent PEDIC papers on observation in children with untreated intermittent exotropia. So, Elad, are you here?
Yes, I am. Can you hear me?
Yep. And can you share your screen? Great.
Sure, yeah. Let me just turn presenter mode.
And just a reminder, the chat box is going on with questions. So if anyone has good answers to the tough questions in there, please feel to answer in the chat box.
Good. All right. So good night to all, or good morning. I'll present the two parallel studies on intermittent exotropia done recently by the PEDIC group. They present 3 years of observation of children either 3 to 10 years of age or 1 to 3 with untreated intermittent exotropia. The ophthalmic and physiological optics paper deals with the younger group, and the ophthalmology paper deals with the older group, 3 to 10 years of age. And the design is the long-term observation arms from the previously reported randomized clinical trials by PEDIC that compared the part-time patching, 3 hours a day, with observation for intermittent exotropia for 6 months in both age groups. And I'll touch these papers just on my last slide. So the methods, all in all, there were about 25 different criteria for eligibility, but I'll just state the main ones, which were the children needed to be untreated except from refractive correction. They need to have near stereoacuity of at least 400 arc seconds or better, but that was just only in the older group. In the younger group, they didn't routinely measure that in all patients. They need to have intermittent exotropia or exotropia at distance, and intermittent exotropia or exophoria, sorry, at near, and exodeviation of at least 15 Pearson diopters at distance or near by prism and alternating cover test, an exodeviation of at least 10 prism diopters at distance. Surgery was not to be considered to be the immediate necessary treatment for the included patients. But treatment was considered only if deterioration criteria were met, which I'll describe shortly, or if protocol approved exceptions were met, which were essentially social concerns or debilitating diplopia, or having stereoacuity, which was less than age norms. With regard to the follow-up visits, they happened initially every 3 months and then every 6 months. And in each visit, both distant and near stereoacuity were measured for the older group, just for them. Distant and near control were measured, and distance and near cover tests were performed. So just shortly, these are the stereoacuity tests that were used for upper distant and lower the preschool for near stereoacuity. And with regard to the control scale, they've used the office scale described by Moni and Holmes in 2006, in which 0 meant no exotropia unless dissociated, and then a very quick recovery. 5 meant constant exotropia, and the grading between them, essentially between 0 to 2, having no exotropia unless dissociated, and 3 to 5 having spontaneous exotropia and just differing on the amount of time. The primary outcome measure was deterioration by 3 years, which was declared if any of the following 3 criteria were met. So the first one was the motor criteria that described constant exotropia for at least 10 prism diopters at distance and near. And that needed to be validated on a same-day retesting. And with regard to the constant feature of that, it needed to be manifest tropia that was present 100% of the time during the examination. But if the child was not tropic at the time he or she was reporting stereoacuity, the near tropia was not considered to be constant. The second criteria was the stereoacuity criteria, and that meant drop in the near stereoacuity by the rendered preschool stereo test of at least 2 octaves and 1 octave doubling of the second of arc measurement. And the third criteria for deterioration was not regarded as being an official deterioration criteria like the stereoacuity or the motor criteria, but still, if treatment of any sort, either surgical or non-surgical, has been received, again, without meeting these former criteria, it also was included in the deterioration outcome. With regard to the secondary outcome measures, they were measured only in patients who completed 3 years without any treatment. And continuous measures were taken, and also dichotomized improvement or worsening cutoffs were defined. And they appear in brackets, but essentially the measurements were stereoacuity, and the dichotomy was considered if 2 log octaves were differing. Control, and 3 points was a dichotomy there, and intermediate exotropia magnitude with these specified dichotomy cutoffs. So to the results, firstly, with regard to the essential baseline characteristics, there were huge tables at both papers, but I just summarized the essentials there. So first of all, with regard to the age, the mean age at the older group was 6, with 60% females, as we know in intermittent exotropia. And in the younger group, the mean age was 2 years of age, with 60% females. The visual acuity, the refractive error, and the stereoacuity were specified only for the older group, and they were essentially normal. And with regard to the subtypes of intermittent exotropia, they were quite similar between both groups, of about 70 or 65% basic intermittent exotropia, and 21 to 27% of pseudo-divergent excess and all the following rest. With regard to the control score, so the near control was quite good with 1.1 or 1.2 at both groups, and the distance control was slightly worse at 2.5. And the exodeviation means by PRISM and alternate cover tests are as follows here. So let's go to the results. I'll start with the older group. As for the main outcome measures in this group, the overall after 3 years, the cumulative probability for any deterioration, and that could have been either stereo acuity or motor or just static treatment, that was 15% or 25 patients. The cumulative probability for stereo acuity deterioration was 7%. And the cumulative probability for motor deterioration was 1%. 12 patients started treatment without meeting the formal motor or stereo acuity criteria, most of them for social concern reasons. And only 18 patients out of the 25 grossly or generally deteriorated patients received treatment. 7 of the stereo acuity deterioration patients did not receive any treatment. And most of the treated children were patched, and that was followed by surgery. Of the 132 patients who completed the 3 years follow-up, and that was about 87% of the cohort, and were not treated during the study, only 1 patient or less than 1% met the motor or stereo acuity deterioration criteria at 3 years. And of the 4 patients that completed 3 years of follow-up who met deterioration criteria previously, and all for stereo acuity, but did not receive any treatment, none met the deterioration criteria at 3 years, which means that they were spontaneously improved. And as for the secondary outcome measures, so significant improvement occurred in distance and near stereo acuity of 0.14 log arc seconds, which means about 50% improvement in the actual measurement of arc seconds. The distance exotropia control improved by 0.6 of a point. And the distance exodeviation magnitude improved slightly with 2.2 prism diopters. And let's go to the younger group. So for the main outcome measures in this group, overall, after 3 years, the cumulative probability for any deterioration, and that was motor deterioration or starting treatment, again, I remind they were not measured for stereo acuity. So the percentage for that was 28 and equals to 24 patients. The cumulative probability for motor deterioration was 10% or 7 patients. And more than twice as much, 17 patients started treatment without meeting the motor criteria, most of them for either social reasons or sub-criteria intermittent exotropia deterioration. All these 24 patients received treatment. Most of them were operated on, and that was followed by patching. And as for the secondary outcome measures, of the 53 patients who completed the 3 years follow-up and were not treated, and that was about 70% of the cohort, only the exodeviation magnitude at distance significantly improved at 3 years. And the improvement was 3.6 prism diopters. And when we speak about it in a dichotomy point of view, so a bit more than a third showed a dichotomic reduction in their magnitude of exodeviation. And for these 53 patients, no statistically significant change was observed for near exodeviation magnitude or for the intermediate exotropia control at both score at both distance or near. So we'll go to the discussion. For the older group, the 15% cumulative probability of deterioration is probably overestimated, and that's because only half of the deteriorated patients truly deteriorated by definition, which meeting either the stereoacuity criteria or the motor criteria. The two motor deterioration had actually reasonable near stereoacuity, so essentially not really having constant exotropia. And the stereoacuity deterioration threshold might have been a bit too low, and actually spontaneous improvement occurred for some of the patients. Also, the same day confirmation retest probably might not have been adequate for an inattentive child, and they suggest that probably retesting them on a different day might have elicited other results. They also mentioned a possible selection bias by enrolling the milder cases and arguing that more severe children were probably treated more or even immediately. But still, their conclusion is that treatment is not necessary for most of the older group, the 3 to 10 years old of age with intermediate exotropia, because deterioration is uncommon. With regard to the younger group, they raised similar points. They did claim that they had low conversion rate of intermediate exotropia to constant exotropia over 3 years, which was 10%. I've added the question mark there because I was wondering if that 10% are truly low. They showed no general worsening in control or magnitude of intermediate exotropia in the untreated group. And their conclusion was the treatment is not necessary for most 1 to 3 years of age because deterioration is uncommon, and suggests that watchful waiting is reasonable. Both studies cited one paper in particular, the Bach paper from 2012, which was also prospective and relatively large, that showed similar results. And their higher rate of motor deterioration in the younger group, again 10% versus 1%, was discussed as well, with no obvious explanation for that. They should suggest that it might be the true natural history, meaning that the more severe cases might present earlier in life. And just before I finish, as I mentioned initially, I'll present one slide on the original short-term PEDIC randomized trial to complete the picture. So with the older group, they showed that there was 6.1% of deterioration in the observation group versus 0.6% of deterioration in the patching group. And that actually a 10-fold higher risk for deterioration in the observation group. And with regard to the younger group, they showed no significant deterioration no significant difference in deterioration, but a trend towards better outcomes with patching and significantly less distance deviation and better distance control in the patching group. So I think that a good summary might be a question, would you treat or not treat? Yeah, and that's the two papers.
Thanks, Ilad. Just a quick comment. Anyone has any comments on these two papers? So would everyone's preferred practice be observe intermittent XTs as long as you can?
Well, these two papers have changed the way I do it. I follow their protocol fairly tightly now. I show all parents an appropriate summary, appropriate to their sophistication and education, summary of what the paper shows. And I have my own symptom score and findings, and that I document separately. And I see all the patients again at 3 months, as they did in this study, and then every 6 months. And and the expectation is that most patients will either stay the same or get better, and a small number of patients get worse. What I found really interesting was the 4 cases that Elad mentioned, where treatment was scheduled, but by the time the patient got around to have the treatment, the patient was no longer, the patients in the older group were no longer eligible for treatment. So the fact that a child clearly gets worse and meets criteria and meets the criteria for deterioration doesn't mean they won't be better 3 months later. So be slow to treat.
Thanks. I think we're running ahead. I mean, a bit behind schedule. So we'll get Shanida to present the next one. So Shanida, you're here. And
can you hear me?
yes. So you'll be presenting Michael Repka's paper, Relationship of Age and Other Baseline Factors to the Outcome of Initial Surgery.
Yes.
There should be a share screen button down below in green.
Is it okay now? Yeah, okay. So, first of all, thank you, Shiva and Lionel, for this opportunity. Actually, I'm a new addition to the group, and I'm a little bit nervous too for this. Okay, okay. Let's go to the paper. This article talk about the relationship of age and other baseline factors to the outcome of initial surgery for intermittent exotropia. And this paper published in American Journal of Ophthalmology on the February 2020 edition. And the study conducted on the behalf of the Pediatric Eye Disease Investigator Group. There also limited data exists on the relationship of age and other clinical factors on the outcome of surgery for intermittent exotropia. So the investigators decided to find out the correlation between these. And for that, they adopted the data from a previous study that they have conducted on the treatment of intermittent exotropia. And that paper was a randomized trial comparing bilateral lateral rectus resection versus unilateral resection and resect for basic type of intermittent exotropia. Since from that study, they concluded that there is no statistically significant difference in suboptimal surgical outcome by 3 years between these two surgical options. They adopted that data for the second study or the current study. So the objective of the study is to determine whether age at the surgery is associated with the surgical outcome of intermittent exotropia at 3 years, and also to determine other factors like sex, race, prior intermittent exotropia treatment, magnitude of deviation, control score, fixation preferences, and near stereo acuity on the outcome. So as mentioned, it is a secondary analysis of a pooled data from a randomized trial. And in this study, they enrolled 197 children of 3 to 11 years of age, and they randomly assigned to one of the 2 surgical procedures of intermittent exotropia. And the data collection for the primary study done from March 2010 to 2017 September. So they included children of 3 to less than 11 years and those with the only basic type of intermittent exotropia, and the magnitude of deviation 15 to 40 prism diopter at any distance measured with the prism and alternate covered test, and they should have at least 400 arc second near stereo acuity. And those children who previously treated with strabismus surgery or botulinum toxin injections were excluded from the study. They randomly assigned into 2 groups, and after surgery, mask examination were performed every 6 months for 3 years, and they look for suboptimal surgical outcome. So what is suboptimal surgical outcome? According to the definition of the study, it is first occurrence of one or more of the following 3 criteria, that is exotropia of more than or equal to 10 prism diopter at a distance or near by simultaneous prism cover test, or a constant ESO deviation of more than or equal to 6 prism diopter at a distance or near by simultaneous prism cover test, or a decreasing near stereo acuity of more than or equal to 2 octaves from enrollment. They also included those performed a re-operation without meeting these clinical criteria. Okay, 2 groups, 2 points were considered for the suboptimal surgical outcome. And come to the baseline demographic and the clinical characteristics they considered for the correlation. First of all, the age at the surgery. Initially, they grouped the all population in all the participants into 4 age group. This 3 to less than 5, 5 to 7, 7 to 9, and 9 to 11. And in later part of the study, they combined these 4 groups into 2. Then they considered sex, race, prayer, intermittent exotropia treatment, and these factors they categorized according to age too. Then also considered position of eye at the time of enrollment. They measure and determined it under general anesthesia, and they classified like those who are not assessed within normal alignment with eye equally exo and one eye more exo, like that. Then deviation at the enrollment also determined, there is no dystentropia, alternatintropia, or one eye more exo like. Then binocular fixation status at near and distance were identified. Then baseline exotropia control at a distance and near were identified using intermittent exotropia office control score that we have seen in the previous presentation. Then stereo acuity for distant and near were determined, and they classified like a 40 to those with the 40 to 60, 100 to 20, 400 arc-second. Then, of course, the magnitude of deviation with both the prism alternate cover test and simultaneous prism cover test is find out and subclassified. Then exodeviation status at a distant and near is like those with the constant exotropia and the intermittent exotropia. So these 2 variables, exodeviation status and magnitude deviation, is for just they measured throughout the follow-up period. So endpoint of the study is when they find out a suboptimal surgical outcome at any masked examination, regardless of whether the patient subsequently improved before 3 years with or without a reoperation. And after the study, the analysis done with the proper tools like a Kaplan-Meier method, Cox proportional hazard regression models, and finally the final model is then adjusted for all the baseline factors. So come to the result. The mean age at surgery for the population, the study population is 6.2 years, where the 62% were females and the 57% were whites. So first baseline factor, that is age. There is a 28% of suboptimal surgical outcome in the age group of 3 to 5 years. That comes around 19 out of 72 children, and 50% in case of 5 to 7 years, and another 50% in 7 to 9 years, and 49% in 9 to 11 years. When they found out there is a potential effect between the age and the suboptimal surgical outcome, they combined these 4 age groups into 2, like a 3 to 5 years group, it is 28%, and a 5 to 11 years group, there is 50% of suboptimal surgical outcome. And the most common criterion then met, first met during the follow-up period is the constant and intermittent exotropia of more than 10 prism diopter, either alone or in combination with the stereo acuity. So there was 74% children in the 3 to 5 years age group with the intermittent exotropia alone, like a more than 10 prism diopter. And in case of stereo acuity, there is no children with the stereo acuity lows in the group of 3 to 5 years, but there is 2% in case of 5 to 11 years. The third criteria, that is the esotropia of more than or equal to 6 prism diopter was met by only 3 people of the total study population. This table shows there is a clear in the 5 to 11 year age group, the percentage outnumbered clearly of 3 to 5 years throughout the follow-up period. Yeah. Then after that, they also calculate the cumulative probability of reoperation by 3 years post-operatively. And there is only 1% probability of reoperation in case of 3 to 5 years age group, but 11% in case of 5 to 11 years age group. Other than age, they couldn't find out any statistically significant association between suboptimal surgical outcome and other baseline factors like age, sex, magnitude of deviation, control, and fixation preferences, etc. So come to the critical appraisal about this study. The strength of the study is this is a randomized control trial, but there is some limitation because this is a secondary pooled data from another study. So the analysis they have done for this study is not a pre-planned analysis. And when come to the sample size, they mentioned that the sample size was small for some level of baseline factors. For comparing some baseline factors, the sample size is insufficient. So that could be a reason they couldn't find out any correlation between some other baseline factors than age. And about the selection criteria, they're well defined, but they only considered those with the basic type of intermittent exotropia and those with the 15 to 40 prism diopter deviation. So we couldn't extrapolate into a general population or those with other type of intermittent exotropia and those with the higher deviations of exotropia. So another thing is they didn't consider the duration of symptom, like for how long these children have this intermittent exotropia, because of that they didn't address the presence or severity of suppression, because in our elder age group there could be a possibility of suppression and a more severe suppression compared to the younger age group, which might affect the outcome of the surgery. Another limitation is the children of 3 to 5 years of age are at a lower risk of being misclassified as meeting the stereo acuity suboptimal outcome criteria, because as the children grows, their ability to do the stereo acuity test and the stereo acuity itself grows mature further compared to the older age group. That could be a reason that there is no children in the age group of 3 to 5 years met the stereo acuity criteria for suboptimal surgical outcome. Another limitation of the study is that a larger proportion of young children had uncertain baseline binocular fixation status, making it uncertain whether the younger and older age groups were comparable on these baseline factors. They also mentioned that there could be a bias in this study when we consider the reoperation percentage. We have seen there is only 1% of reoperation, probability of reoperation in the younger age group compared to 11% in the older age group, because the discretion of whether to do the reoperation is completely the discretion for the investigator. Since there is a social concern in case of older group, that might be the reason there is a higher rate of reoperation happened for the elder age group. Then the results were simply represented, but they didn't address whether early versus delayed intermittent exotropia surgery is associated with a better outcome, because they didn't consider the duration of the symptom, or they just classified the total population into two surgical groups. They didn't consider it as like it's a early surgery or deferred surgery or a immediate surgery. So the further studies needed for this to address this factor, like whether the early surgery or delayed surgery gives a better outcome. So from this paper, we can conclude that children of 5 to 11 years of age at the time of surgery for intermittent exotropia were twice as likely to experience suboptimal surgical outcome by 3 years after surgery than children of 3 to 5 years. And the suboptimal outcome has no association with the baseline factors like sex, race, fixation preferences, magnitude of deviation, and stereoacuity. And further studies are needed to address the question of whether early versus delayed intermittent surgery is associated with a better outcome. Thank you.
So that completes all the papers that we chose on intermittent exotropias. And so we can have a bit of a discussion on this. So Lionel, this paper makes it seem that early surgery is better, whereas the pedic studies show the opposite. So any comments?
Selection bias is the bane of my life and yours and all of ours, I think. Yeah, Glenn, some wise comments from you?
I agree that there's some selection bias there, Lionel. There's a lot to digest in these papers. Yeah, and it's just interesting to me that they're esotropes, such a small percentage of them were overcorrected into esotropia, and that's the reason given for not operating on the younger child. So maybe we need to reconsider that, like everything else.
And I think maybe another conclusion, Glenn, what do you think that if a 4-year-old child clearly has a constant exotropia that is bothersome to the parents, then it is sensible to offer an early operation with fairly good expectations?
I think before tonight, Lionel, I would have said no, but after tonight, I might have said yes. Of course, the early versus late surgery argument with intermittent exotropia has not really been made much before, because the ETs, there's a clear sensory benefit. But we just during the chat group, people were talking about stereopsis, and I still don't understand why stereopsis deteriorates in such old children. It seems when it develops so early in the child's visual development. Well, we all talk about, we all measure it, but what does it really mean? Is it a real phenomenon?
That's a very good question. Is it real? Well, in lots of cases that I referred to, just measure them again another day, and they'll sometimes be better. So, one swallow doesn't make a summer.
Question. So if we leave an intermittent exotrope kid untreated for a while, and this kid now turns into a teenager and has lost control, is exotropic most of the time, is there any chance he can regain stereo if we aligned him, say, later on in his late teenage to early adult years?
Well, I've certainly have many anecdotal cases where the answer to that question is yes. So I think the threshold, we're not going to discuss today what our thresholds for surgery are, but I think we can rely on the thresholds of the two pedic studies. And it's interesting that about half the time treatment was initiated for non-protocol reasons. And that probably happens in my office too, that treatment is most commonly initiated by the parents and sometimes by me for a child whose abnormal appearance in the first year of school either has or threatens to interfere with normal, with self-esteem and with normal social development. Does anyone else agree or disagree?
I agree with that, Lionel. This is often parent-directed, and possibly in both directions too. I often see teenagers with to me, quite unsightly squints, and they're really not concerned about it. So
Yes.
I just tell them to come back when their love life goes off the boil.
Or doesn't get on the boil to start with.
At all, yes. New South Wales Premier. Oh, see, another story.
Anna, you don't know what we're talking about, but we have Australia is very saucy at the moment.
No, I agree with those views, but I think it does introduce the fact that if the little ones that are deteriorating, they may be a separate group. They may have something primarily not quite as good, or they're not so set in their ways about how they're doing things. So that's maybe a good thing, or it may be a bad thing. So it may account for some of these age differences. But I think most in the UK, I think most people are sitting on them for a lot longer. And the advantage of sitting on them for a long time is that you get an overview of how bad they are. You're not just seeing them once or twice. You've got 4 years of whether there's a trend in one way or another. And if the trend is downwards, then it's easy to be more confident that actually it's genuinely down rather than they're just having a bad day and it's the end of the afternoon.
Robbins had a question in the chat box. Does anyone use deterioration of near fusion range as an indicator for intermittent XT?
I'm very keen on the fact that what you tell the patient about the fusion range is absolutely critical about how good a range they do. So if it's you doing the fusion range and your instructions are exactly the same every time, then you might notice that there is a deterioration. But if somebody else tested that fusion range and you test that fusion range, I can guarantee that I will get double the fusion range of any student I'm supervising just because I approach the patient differently. And we demonstrated that that instruction set and effort makes a massive difference. So you've got to be really sure that your testing is spot on and repeatable, and you absolutely do it the same way every time, and preferably it's you that's done it. Otherwise it's really difficult to rely on a fusion range, and often they just suppress when it goes, so you've got to be really quick at spotting when they've diverged. So I wouldn't be desperately reliant on a fusion range, because half the time they suppress and they've diverged before they've told you that they need diplopia, and you might have missed it.
Yes, there's a Frenchman called a French rheumatologist called Dr. Paris, who comes from Lyon, of course, and he has got a simple screening test for motor fusion, and that is a 6-diopter lens. So if a 6-diopter converts, say, Fourier to atropia, that's useful knowledge. And for me, it's sort of it helps to stratify these patients, segregate them into those who've got robust fusion veneer and fragile fusion veneer. And I'm not sure that one needs to know more than robust or fragile.
No, I think I agree. I think there's, because they are very prone to good and bad days, and I think that you do need to watch them over a while to see how they're going. And I think over COVID, it's been worse. I think I've had a lot of sort of kids have got better or worse in the sort of 6 months that we haven't seen them. And they seem to be more affected by doing more close work or more little screens or less or stress or that sort of thing. So I think at the moment it's quite difficult to make decisions because they've had such funny lives for the last 6 months.
Yes.
Well, last part of our journal club is on infantile exotropia. So the last 3 papers are about infantile XTs, and Jack's here, so we can go on to his talk. Jack, you here? Yeah. Okay.
So I did the Hunter and Ellis paper from 1999 about prevalence of systemic and ocular disease in infantile exotropia. So yeah, the classic teaching is that infantile exotropia is associated with an increased prevalence of neurological, ocular and craniofacial abnormalities. But at that time, the prevalence of all those was unknown. And so they compared a series of infantile exotropia patients against a series of infantile esotropia patients. And by doing so, they aimed to establish what the prevalence of each of these was. So the patients that they had were all the outpatients that had infantile exotropia within the first year of life from 1980 to 1994 at Wilmer. And they took the things from 3 physicians, which was Guyton, Hunter and Repka, or the resident service. And then they selected a random set of patients with infantile esotropia. They included both small angle strabismus and intermittent strabismus. They excluded patients who weren't examined before their first birthday, and also patients whose strabismus resolved by 3 months. And then they divided the patients into complex and simple groups. So the simple group was patients that had no existing ocular or systemic disease beyond sort of expected associated conditions of strabismus. And then the complex group were those who had other associated ocular or systemic diseases. So these are the systemic and ocular classifications that they split the patients into. And then because they were worried about a selection bias, it was because Repke was a pediatric neuro-ophthalmologist. And so he got obviously more complex and patients that were more likely to have systemic associations. Then they split. Group 2 was just the resident service at Wilmer. And then group 3 was the other 2 ophthalmologists. And then essentially they assigned each patient to a group based on what was the most specific diagnosis. So say if they had cataract and nystagmus, then they were assigned to the anterior segment disease group rather than the nystagmus group. And then, yeah, I did statistics on that. So they ended up with 70 exotropia patients, and they had 310 esotropia patients, but they randomly selected 136 of these. And so a high percentage of both the exotropia and esotropia patients had coexistent ocular or systemic disease, with exotropia more likely to have a coexisting diagnosis. And so this was seen in all 3 of the subgroups, which was, yeah. And so because of that, then for the rest of the analysis, they grouped all the patients together. And so the risk factors for having complex strabismus that they found was that for exotropia, that a constant exotropia was more likely to have be complex compared to an intermittent exotropia, but this wasn't seen in esotropia. And they found that a smaller angle for both esotropia and exotropia gave a higher risk of having a complex strabismus, although the angles that they measured were like very, very close to each other. And they didn't find any effect of gender or race on having complex strabismus. So in complex strabismus patients, they found that they were more likely to have a systemic disease rather than an ocular disease. The most common systemic was this neurological disease category, followed by prematurity. The most common ocular diagnosis was ptosis, and that was more likely to occur in exotropia patients. So these are just percentages of how often each of the exotropia or esotropia groups fell into these categories, or the numbers actually. Yes, the associated systemic diagnosis is shown, as well as the frequencies of each. What was interesting, only 1% of important systemic diagnoses were made by the ophthalmologist rather than the referrer. So for the most part, when the patients came to the ophthalmology clinic, they already had this systemic diagnosis. And associated ocular disease with ptosis was more likely in exotropia patients compared to esotropia patients, and nystagmus was more likely in esotropia patients compared to exotropia patients. So 25% of these ocular conditions weren't diagnosed by the initial referrer to these centres. The problem is that there is some referral bias, that they included sort of both without a significant sub-analysis of the groups of small angle versus larger angle or intermittent versus constant. I don't know exactly why they stopped at 136 patients. I guess probably 310 was too many to go through. And then there's some statistical problems with it in that there's some multiple comparisons made that they don't correct for that in the statistics. So the major takeaways from this study is that infantile exotropia is frequently associated with ocular and systemic anomalies, which was sort of known, but also that infantile esotropia is strongly associated with these as well. That all patients with horizontal strabismus should have careful ophthalmic evaluation for both visually significant and life-threatening pathologies. And that whether the deviation is intermittent or constant and the size of the angle are not reliable in determining which children are at risk of coexisting disease. So it doesn't particularly help. You need to look for the life-threatening and visual-threatening things for all patients. That's all.
Thanks, Jack. Any comments?
Well, there's a lot of selection bias in that the two Davids and Michael probably collect patients that have more pathology, I would suspect, than suburban pediatric ophthalmologists in Baltimore. I don't know. I've never been to their practices. Does anyone know?
They certainly make a comment on that in the article, that the community ophthalmologists have likely have a much lower percentage.
So, Glenn, what do you teach your fellows about seeing a child with infantile exotropia? Do all have to go to a pediatrician or a pediatric neurologist?
No, but I think this is a real phenomenon. Many of these children have other syndromes, and they're fortunate that so many of their patients have got a diagnosis, because I seem to have made diagnosis often in children who are referred for infantile XT and raise the suspicion or make a clear diagnosis of some abnormality that's not been previously suspected. I'm just curious about why this database is so old. They've trolled through charts that are 40 years old to find...
The paper was from 1999.
No, but...
It was published, sorry. Yeah. But yeah, it was still 19 years ago.
It's, okay, sorry. I didn't see that. Okay, that makes some sense. But it needs, well, if that's the case, someone needs to redo it with the last 25 years of data, because they might come with quite a different conclusion.
Yeah. There's actually not a lot of papers out there on infantile exotropia. There's very few. So I think we'll probably pick the top 3 that we could find.
I think the Royal Children's or the Eye and Ear Strabismus Service needs to crank out a paper on this one, Lionel.
I see, I'm sure it'll be a very different paper from the eye and ear doctors and from children's hospital doctors. I see a steady trickle of infantile exotropia, and probably the majority just get better without treatment. And
Oh, that's very interesting.
isn't it? But very few of my patient cohort would get the label complex, and the majority have no significant developmental or neurological pathology.
They may be being seen down the road at the children's hospital. So just comparing the two institutions might be quite a useful thing. Put the fellows to work.
Well, there are 2 or 3 on this.
We've got 2 fellows for next year, so Elad and Will. That's okay. Tanya, now this is an interesting paper. Lionel suggested that this paper should be discussed, and the only paper I could find was in French, and we could find a registrar who speaks French. So thank you, Tanya, for helping out and translating this paper for us.
Thank you, Shiva. I'll just share my screen. Okay. Can everyone see my PowerPoint? Great. So, bonsoir à tous. Je vais vous présenter l'intérêt de l'IRM cérébral dans les exotropies précoces. Good evening, everyone. I am Tanya, the Neuro-Opthal Registrar, and I'm going to be presenting this paper. Not in French. I have taken the liberty to translate it at everyone's request, and so the focus will be on infantile exotropia and the importance of cerebral MRI. There is a bit of overlap with Jack's paper, so apologies if I'm repeating a few of his concepts. The paper was published in 2008 in the Journal Français d'Ophtalmologie, or the French Journal of Ophthalmology, and their purpose was to report the results of MRI brain findings and associated ophthalmologic and systemic disorders in infantile exotropia. The design was an observational prospective cohort study over 3 years, and the assessments were not specifically outlined, but from ascertaining where the authors came from, I think they were all conducted at the Children's Hospital in Marseille, Hôpital Timon, and the neuroimaging itself under GA was conducted at the Adult Hospital, also in Marseille, so right next door. The methods for this study were pretty simple. It's not a very technical paper. The inclusion criteria were merely that they included children aged from day 1 postnatal until 2 years old, and they had to have had a constant exotropia. So intermittent exotropia was excluded, and there were no other exclusion criteria specified. The population of the cohort studied were 47 children, and again, aged day 1 to 2 years old. The mean age they described was 16 months old. There were 19 girls and 28 boys. All children underwent a perinatal history and general examination, looking at systemic disorders, as well as an orthoptic and ophthalmic examination. And then all children subsequently underwent an MRI brain under general anaesthetic, which were all analysed by the same paediatric neuroradiologist at the adult hospital. So a little bit more detail about, there was a lot of detail in the variables that they were looking for. The perinatal history included prematurity as well as fetal or neonatal insult. So I'll just highlight these briefly. I'll read through them because they become relevant later. So anything like hypoxemia, gestational diabetes, vascular events, maternal eclampsia or placental pathology, as well as cord pathology, fetal infections, trauma, anemia, and any insult or injury during the childbirth process itself. The general assessment that they described included looking for features of facial dysmorphism or any syndromic features, plagiocephaly, seizures, chromosomal abnormalities, oculomotor apraxia, as well as psychomotor developmental delays. The orthoptic assessment sounded rather straightforward. They just measured the deviation, and then they divided the angle of deviation into 4 groups. So minor angles at less than 4 degrees, between 4 and 10 degrees, between 10 and 20, and then the largest at over 20 degrees. They then underwent an ophthalmic assessment, which assessed binocular vision, looked for amblyopia, congenital cataract, any abnormal head position, nystagmus, oculomotor function or palsies, including Duane syndrome, and also features of albinism, retinitis pigmentosa, and optic nerve abnormalities such as hyperplasia of the nerve or optic pits. The MRI findings that they were looking for were abnormalities of both white and grey matter, with a few points under there for you to peruse. Ventricular megaly, hydrocephalus, dilation of spaces including subarachnoid and vertebrobin, which is perivascular spaces without mass effect in the brain. Looking at abnormalities of the corpus callosum or the septum pellucidum, and they included the septo-optic dysplasia, which affects the nerve and the pituitary gland also, arachnoid tumours or cysts, and rhomboencephalosynapsis, which I had to look up, and that is the absence or dysgenesis of the cerebellar vermis in the posterior fossa. So their results, I'll just start with the table displaying the MRI results. So the table on the left, I have left it in French, so if anyone has questions, they want me to translate extra features over the next few slides, please just speak up. This first table divides the MRI results according to those four groups based on the angle of deviation. So they spelt out that 72% of all of the MRIs performed were abnormal. And you can see here that the smaller angle deviation and the very large angle deviation were at the smaller end of this spectrum, with the majority of abnormal scans being between 4 and 20 degrees. However, the table on the right divides it then into two groups, so above and below 10 degrees. And they're trying, I think, to tell us that there were more pathological scans in the greater angles of deviation. So I sort of recalculated, and in the 57% of patients that had less than 10 angles of deviation, 59% of them had an abnormal MRI. And in the 20 patients, or 43% that had the greater angles above 10 degrees, 90% had an abnormal MRI. And my understanding of an abnormal MRI were any of the features that were outlined on the previous slide. A bit more detail on the MRI findings. So 13 out of the 47 patients had normal MRI findings, and the remainder were considered abnormal based on these sub-definitions. So exclude the normal scans and just count the numbers that had abnormal. They found that white matter abnormalities comprised 62% of the abnormal scans, grey matter abnormalities were 41%, and the majority they described as diffuse brain atrophy rather than focal insults. Just out of interest, corpus callosum and septum pellucidum abnormalities, which are quite major, 18% of these scans, and tumours comprised 8% of these scans, with 1 craniopharyngioma and 2 benign tumours not otherwise specified. I'll mention this at the end of the slide, but they also didn't consider any orbital findings, so whether or not there were any lesions or other things affecting the extraocular muscles were not considered in this study. Would anyone like me to explain anything in that table, or maybe at the end? Okay. Ophthalmic signs they associated with infantile exotropia. So they said that 77% of patients with XT had an associated sign. The most common ones I've highlighted, so nystagmus and abnormal head posture, and amblyopia and optic disc hypoplasia or pallor. And then they did comment that in addition to exotropia, the signs were present in equal amounts in both normal and abnormal scans. So they conclude that ophthalmic signs in the presence of infantile exotropia is not in itself an indication to undertake an MRI scan on a neonate. The third parameter were general congenital conditions. So 62% of patients with infantile exotropia had an associated systemic disorder. The more common ones were plagiocephaly, prematurity, with no comment about any associated issues, just prematurity by itself, insult or injury in utero or perinatal, and the history of afebrile seizures, and psychomotor delay as the last one there. They then commented that isolated primary exotropia with no ophthalmic signs, normal MRI scan, and no systemic conditions only were found in 6% of this cohort. limitations of this study were quite a few. It was not so technical in the end. So it was observational and non-longitudinal, and there was no specific information or detail about visual acuity or binocularity outcomes for these children. The inclusion and exclusion criteria were quite straightforward. It didn't really identify how these children were selected, if it was everyone that presented in a certain time frame or not. The age of onset wasn't stratified. I don't quite know if that's very important, but I thought it might be interesting to see if the children were born with it or if they developed it, after 6 or 18 months even. And a lot of the variables that were described in the history, the few slides I spent outlining, they weren't then presented as numbers or correlated to any other signs or findings. So I thought it would have actually been really nice to have a table with the 47 patients just outlining their age of onset and any associated features, just for us to look through as an additional resource and understand the numbers a bit, but that wasn't available. It was limited scope, so it's just about constant XT and no comparison on intermittent exotropia. So Jack did touch on that, but whether or not MRI scans in those patients would reveal anything further is uncertain. And as I've flagged earlier, the MRIs did not examine the orbital aspect of exotropia, if there's anything affecting the muscles. It only examines the brain. The conclusion by the authors were that the majority of MRI scans they conducted were abnormal, with increasing incidence as the angle increased, in particular over 10 to 20 degrees. Many patients with the infantile XT will have other signs or a general condition. Other ophthalmic signs were equally present in both normal and abnormal scans, so they don't warrant the neuroimaging. And comparable point, prematurity and perinatal insult were also common in relative numbers, both normal and abnormal scans, and by themselves also do not warrant neuroimaging. So finally, they said we should consider MRI brain looking for underlying pathology in these patients if the deviation is greater than 10 degrees or if there is a clinical association with a general congenital condition. And that's just wrapping up with a picture of the beautiful town where the hospital is. Speaking French might consider that one day. Thank you.
Thanks, Anya. That was excellent. Okay, I think we'll finish off with the last presentation because it's a very short one. I've looked at Anthony's presentation, so we'll finish that off and have about 10-15 minutes for discussion before we wrap up the journal club. So Anthony, do you want to do yours quickly?
Absolutely. So let me figure out how to do this thing. So my paper is the corollary to Jack's paper. Essentially, it is in the population of infantile XT that does not have any systemic condition, what happens to them? I suspect that Dr. Caval will have more to say on this as well. So in this 2001 J-PLOS paper by Hunter and Ellis, basically looking at the same population that was used in Jack's study, looking at this retrospective review at the Wilmer Institute of 1980 to 1994 of all patients diagnosed with an XT before 12 months of age. And they included both intermittent or constant, and just basically any diagnosis between in that first year of life, excluding any misalignment that resolved before the age of 3 months. And they also took out basically any patient that had any significant systemic disease, including prematurity that was under the age of 37 weeks, and any patients that were followed up for less than a year. Now, with this extremely large time frame between 1980 to 1994, they then looked at basically categorized this between intermittent versus constant. When was this first noticed? How big was this initial alignment? And at the last assessment, how big was the alignment? Was there some development of some binocularity as measured by Wirth 4 dot and Titmus fly? And what was the treatment in terms of surgical? Was there surgery or not? Usually for constant XT or loss of control. Out of that big time frame, they found 13 patients with XT that was diagnosed before 1 year of age. Roughly 7 with intermittent XT and 6 with constant XT. In the breaking down these two particular groups, the constant XT generally had a larger deviation on at diagnosis compared to the intermittent XT. In general, they trended to being younger at age of first noticing, around about 1.3 months of age of onset compared to 3.8 months of age of onset. Although this was trending towards significant, but didn't reach exactly 0.05. The majority of them, more than 90%, underwent surgery. And although about 1/3 of them ended up going to having some kind of reoperation, the vast majority of them ended up with a good alignment following the surgery. And as tracking the clinical outcomes of this small group, around about 70% of them developed some degree of gross binocularity, as defined by able to see the titmus fly or a fusing on the Worth 4-dot test. But none of them developed really good stereopsis. In terms of the discussion points that Hunter and Ellis talked about, was that majority of these patients in this particular cohort, whether constant or intermittent, will eventually require surgery. And so they posed the question of, given that the outcomes between these uncomplicated infantile exotropias seeming to be largely comparable, are they essentially variable expression of the same disease, just on different ends of the spectrum? I'll now open this up to discussion.
Wow. I think it's a very interesting paper, and there is another interesting. There's a reference in the paper to Hiles, and Hiles around the same time, he was from Pittsburgh, and he looked at infantile exotropia, and of patients who he booked for surgery but ended up not having surgery, when they were later reviewed, 25% no longer had exotropia. So that figure of 90% will have surgery. I'm not sure that that's always true. Glenn, are you still here, or have you gone?
I'm still here. I can't comment on that, Lionel, because I've always thought infantile exotropia and infantile esotropia were part of a spectrum, so I tend to operate on all of them. That are constant. So I have no natural history, no basis for reporting on natural history. I was assumed that you had to operate on them early for the sensory aspect.
Well,
interesting.
Yes. I don't think it's that simple.
Lionel, why do you think they get better? Is it because I presume if they're born with or they've got infantile XT, they should have no reason to get better?
Look, I've just in the last week or two, when consulting has become nearly normal again, I've just seen two or three patients who I've had seen in previous years with infantile onset exotropia, one of whom I operated and two of whom I didn't. And the didn't ones, one of them was constant 45 diopter XT, and when first seen, and I said, come back in a month or two, I'll have another look. And I just watched the kid get better. to the point of not needing any surgery. So I think this is a mixed bag. I don't, yeah.
There's a few questions. Sorry.
Can I just add on something? I saw a case once, because we've been seeing babies from pretty well from birth. I did see one baby. You have to be really careful with the neonates, because all babies look divergent if you look at their corneal reflections, because angle kappa is so much bigger in babies than after 6 months. But this baby had, even I thought, was a massive constant exotropia. It came in as a normal control, but I watched this baby very carefully, and then at about 3 months it went away. And it disappeared, and it went away, and it went away, and we used to discharge that, get them out of the lab at a year, and then 3 years down the line, it pulled up in the orthoptic department with an intermittent exotropia. And I had definitely seen this baby had a very large deviation, and it completely disappeared. And I was quite happy to say, no, we don't need to refer you or anything. And then it came back. So there's something going on.
And one of the small group of patients I've seen the last couple of weeks, there's also been an infantile exotrope that ended up with spontaneous consecutive esotropia a few years later. Yes, I think it's a mixed bag. I think we need to maybe collect some of these patients.
I was interested in the paper that Tanya, the French paper. How did they measure these tiny, how did they do a cover test? I'd missed how they'd actually assessed these very small angle exotropias. I think I'd struggled to find one if they were using any sort of objective method of those small angles.
They only said cover test, so they didn't specify any prisms used or any other.
I wondered if they were looking at a prism reflection method or not. I missed that. Sorry.
No, they didn't. They didn't specify, just cover test.
Right.
And there's a question for you.
There's a few in the chat box for Anna. Any thoughts on accommodative spasm risk when you're using minus lenses for intermittent XT?
Stressy kids. I'm really interested in accommodative spasm patients, and I think so many are not to do with their eyes that if I had anxious parents, anxious patient, I'd be quite concerned. But I think your average laid back intermittent exotropia, I wouldn't be too bothered. I think actually, I think it's very unlikely that you'd induce it, and if they showed any signs, I'd just stop doing the lenses.
Okay. And
I do think different positive fusion range before or after. Yeah, somebody's asked, would you think there's any difference in measuring positive fusion ranges first before you measure negative fusion ranges? What do you say to your patient when you measure? People say that it's better to measure a negative fusion range before positive because you might induce some tonic convergence. I suppose if you're going with that Jampolsky theory that it's you're converging or you're not, then it might be better that you're less likely to induce tonic convergence. So probably do divergent range first. Basically, if I'm doing a fusion range, I just tell them you've got to try. I'm going to make this task difficult for you. You've got to try as hard as you can to stop it happening. So, you're looking for double vision or blur. And when you can't keep it single, I'm going to make it hard for you. You've got to try hard. And then I keep on encouraging them throughout. So I make sure that they've got what I'm talking about. But then I say, go on, yeah, that's fine. Keep going. Go on, you're doing well. Go on, keep doing it. If you change that instruction set, if you say, I want you to tell me when it goes double, the task that you've set them is to look for the diplopia. And the minute they spotted it, they thought, right, I have succeeded in the task that she's given me. I've spotted diplopia. Aha, spotted it. Yeah, that's gone. If you say, I'm going to make it hard, you can double the range. So I think probably fitting your instruction set towards the really enthusiastic, trying hard end of it, and making sure that it's standard is the thing. And if I'm doing exercise, then you sort of switch on personal trainer mode, if somebody's asking you to do that last few bench presses or whatever you're doing, then I sort of go a bit over the top. But generally I'll say, I want you to keep it one for as long as you can. Yeah, you're doing well, keep going. Yeah, that's fine, good. And just tell them that they're meant to try hard, because it makes a massive difference to the range. In fact, we did a study in the lab, and we gave them 8 different sorts of orthoptic exercises, including two control groups. We had one control group that they didn't do anything. We gave one control group that we gave them an actual placebo. We gave another control group that we didn't give them any exercises, and then we gave 5 other groups different types of orthoptic exercises. And the thing that made most difference to the fusion range wasn't any of the exercises, it was what you told them. So, I'm a bit more humble about what orthoptists offer now. I know I'm a good therapist, I'm a good personal trainer. I make people better because I've told them I'm going to make them better. The accommodative spasms, I say, yeah, I understand what's happening. This is because this is what's happening. I understand, don't worry about it. This is what's going on. Sort out your life. And often that's much better than giving them minus lenses. But, and again, I know that all I'm doing is offering a bit of counselling.
Well, Anna, it's been wonderful having you as our guest, and a pity that you can't hear the applause.
Thank you very much. It's
it's
quite hard work, isn't it? Sitting in front of a screen somewhere, sitting in your kitchen, doing a sort of heavy theory sort of conferences. It's quite challenging. But thank you very much for inviting me. I wish I could have been there in person. It would have been much more fun.
Well, I think this format has turned out to be very good. We can have many more participants and spread the message.
Lionel, this is the best attended OMC Journal Club. We've had up to 45 participants at one stage, and even at 9:40 we've got 33, so we're doing well.
I think it's been brilliant, Lionel.
Okay.
Well done. Thank you.
Thank you, Glenn. Thank you. Okay, well, there may not be time for another one before Christmas, but I think this will be the format next year. We'll just pick a topic and explore it in depth.
Yes, tear it to bits, Lionel. That was what was done tonight.
And the response I want is, I have changed the way I'm going to do things.
Yes.
As a result of the Journal Club, and I think I will change the way I do things.
Well, that was wonderful. Thanks, Lionel.
Last question. This has been recorded. So is everyone okay if I create a Journal Club YouTube private channel and put it on there and share it to the group who's attended? Any objections to having this YouTube video uploaded?
I'd be comfortable about sending it to, is it Moodle at Ransco?
Yes.
I think it would be a good idea.
Sure. Okay.
And everyone agree with that? Yeah. Okay, thank you, Shiva. You made it all happen.
Yeah, Shiva, well done.
Thank you. Well, good night.
Good night.
Good
and
night.
Good morning, Anna.
Thank you for inviting me. Bye-bye.
Bye.
Bye. Bye, everyone.
Bye, everyone.
Bye.
Bye.
Thank you, Shiva.
Thanks, Anil. Yeah. I'll have to re-listen to some of the talks again. Reread a few things to get the whole gist of it. Okay.
Yeah. I've got ask Raghu if he copied Kushner's lecture. It doesn't have anything more than his chapter, or barely, and but I don't know how to copy it. Maybe Raghu managed. And
you mean on the Vespos online,
Yeah.
the one that you did? Okay, I'll ask him.
Yeah. Okay.
Okay. Well,
See
good
you
night.
soon. Bye.
Bye bye.
Bye.